This is Evie.
This is Alyssa.
This is Chelsea.
And this is Caroline.
Welcome to Med Surg Moments, the AMSN podcast.
This podcast is an engaging look at the lives of and surrounding medical surgical nurses.
We are all together today for this 58th episode. So I want to start off by welcoming everyone and asking, how are you?
Doing just fine.
Hey guys, it's Chelsea. I actually had my wisdom teeth pulled 6 days ago, all four.
Uh-oh.
But other than
that's
that,
rough.
Yeah, it actually wasn't that bad. No, it wasn't that bad. Maybe like the first 2 or 3 days, the pain was pretty persistent, but I think I'm like out of that window now. It was bad, but I will say that they did put, as people like to say, they put me under. That was a pretty fascinating experience. The doctor, before he pushed the verse, he was like, "Do you have any questions?" And I was like, I don't even remember saying yes or no.
That's hilarious.
I was like out. So
that has to be like an anesthesiology trick, like a personal inside joke for them. It has to be.
Yeah, that was my first time ever being sedated. So it was quite an interesting experience.
How about you, Alyssa?
We're also experiencing some nicer weather. So I'm actually getting ready to leave town this weekend to celebrate an anniversary and be a tourist in my own state. So that'll be fun. Do some road tripping. And yeah, that's what I'm up to. I'm really excited. I'm trying to be focused, but I'm really excited. I've got my brain halfway out of town right now.
Wow. Well, I want to just let our audience know they can't see us, but Alyssa's microphone and her blocker is always so perfect.
I strive for perfection. I've got to make our producer happy.
Unlike me, who has a dog who doesn't make a sound for 23 hours a day. And the second we decide to record a podcast, he goes absolutely crazy.
Exactly.
He's worse than a child.
He wants to be part of the team.
Exactly.
Other than your dog, Caroline, what's going on with you?
Oh, yeah. My baby turned 21 this past week.
Wow.
I'm officially the mother of 2 adult children now. So we had a really fun evening on a dinner cruise around Tampa Bay, which was very nice.
Very cool.
That sounds almost normal. What?
Almost. Wow. Yeah, almost. Wow. You know, Florida's the rebel state. We have been from the beginning, really. So
yep. I love it.
Not much social distancing going on, that's for sure. But fun time was had by all.
What about you, Evie? Yeah. What you got going on, girl?
It's just been busy over in my parts of the world here. The weather has been breaking, which is very good. And people are still adjusting or readjusting to all of the post-pandemic changes again, getting back to quote unquote normal. And other than that, I'm looking forward to leaving town a little bit later this summer. I pushed it back a little bit just because I want to get some work completed, but I am looking forward to doing that. I have 2 new nieces that I have not seen yet. So I'm looking forward to that.
Yeah, no kidding. That would be exciting. How old are these nieces?
One she just turned 1 and the other is just born.
Oh wow. My gosh. Yeah. You got to meet them.
I know, right?
Something to look forward to for sure.
I think that's a good segue, talking about life. And now we're going to talk a little bit about death in nursing, just dealing with death, our patient deaths as we are accustomed to. I don't know if that's the right word, but as we have experienced during our nursing career and, how that affects nurses, how that affects families, and just how we deal with grief after our patients have passed on.
I think this is a great topic. I'm really fortunate to have a strong background in geriatrics and palliative care. So at the end of my 3rd year and the beginning of my 4th year at UVA, I joined this program as a joint initiative between the School of Medicine and School of Nursing, just trying to get us comfortable with initiating end-of-life conversations with our patients. So it was a 3-week program. We talked to nurses who were oncology nurses. One worked at different hospitals and their experiences with starting to initiate, we call them goals of care, to try to help reduce the suffering of the patient and also get some feedback from the patient while they can. What are your wants? What are your desires? What do you want your care to look like now that we're not running out of options? But we should start having this conversation. Taking care of actively dying patients can be challenging. I think that I'm really grateful for that we specialize in that. There are lots of signs and symptoms that come along with dying that a lot of people don't recognize, especially when it comes to pain, because a lot of them aren't verbal. like they're actively dying. So it's nice to be able to provide that comfort and care, and also education for our patients at the end of life. So
that sounds like an amazing experience that you got, Chelsea. I wish that every nursing program had something like that. When I was in nursing school, we didn't have any specific training or opportunity to enhance our knowledge around taking care of a dying patient or how to have those conversations. I remember being at the bedside and having that first patient that was on palliative care and being afraid, not really understanding the care of a patient on palliative care basically goes against everything that you're trained to do as a nurse, because you want to do all of these interventions that are going to lead to recovery and return the body to homeostasis. And essentially, a patient on palliative care that's in the active stages of dying, that's not your goal. The entire goal is to lead to a comfortable death. And not having the language and the confidence to be able to speak to what our plan was, because being a baby nurse and being horrified at the idea that I'm on a med surg unit and people come in 2 days and they leave better than they started. And now there's just this patient thrown in the middle of it. That's not my goal and that's not my expectation. And it was so difficult for me to figure out how to navigate personally my own mental, you go in this room and you're going to be great, you're discharging tomorrow. And then having to slow that energy down, going into the next room and being somber and being respectful to this family. And really you're attending to the patient family needs, because the actual patient is in the active stages of dying. And if you are attending to the patient needs, managing their pain, managing their airway and all that kind of stuff, that's it. That's all they need. You're not taking vital signs. You're not monitoring things. You're not giving medications to intervene. You're not making sure they're getting up with physical therapy so that they can return to home. And it's those first experiences, if you don't have the training and the knowledge that goes behind taking care of a dying patient, it's incredibly overwhelming and against everything that we've been trained to do.
I can empathize with what you're saying, Alyssa. One of the reasons I became a nurse was because of my grandma and seeing how she passed away. Sounds a little odd, doesn't it? But I saw so much empathy and compassion from the nurses when she was diagnosed with liver cancer. And I wasn't there when she passed away, but the biggest thing I took away from it was the nurses were very intentional about asking us what her wishes were, where did she want to die, how aggressive did we want to be with care. And it was a language that we really were not familiar with. But the biggest push of all was, where is your grandma going to be the most comfortable? And that was at home. And so all the stops were pulled out to get her home so that she could pass away surrounded by her family. And I had to get used to the terminology. I think Chelsea just said that patients that actively are dying, they're going through this process. And we have to be very intentional about supporting that. Of course, we're always taught it's about the patient, but in this situation, it's all about the family as well. And I always kept that with me whenever I had a patient that we knew was going to pass away, even though I worked on a surgical floor. It didn't happen very often, but when it did, it was always a wrench for all of us. And I think that family support and everything that we can do to help them through this is also very important. There's nothing cheerful about this subject, but again, it is part of life. And I think as med surg nurses, we get so much thrown our way that it's really important to be able to recognize those signs and symptoms that you were talking about and be comfortable in conversations with the family. Cultural differences come into play as well. I vividly remember in nursing school in England, we spent what seemed forever learning how to prepare a body after they had passed away for the morgue or to the funeral home. And a lot of my American colleagues were quite shocked when they saw the English nurses lay this patient out and prepare them for their last journey, if you will.
Wow. This is, I guess I would say, very fresh for me, and everything that you all have said comes to fore in my mind about a recent patient that I had. A relatively young lady who was dying, and her significant other was in the room. And quite often we get family members who, I guess they're in some degree of denial. But this patient's significant other, he just did not understand. He kept asking me, I was her nurse. I was fortunate and honored to be her nurse. He kept asking, is she going to come back home, or when is she leaving? And those kind of questions. And initially, I thought maybe he had some kind of cognitive deficiency, but he didn't. He just didn't understand, because he told me that she's been through this before and she's always come home. This time she was actively dying. And throughout the course of the shift, I tempered what I would say and when I would say things to him. And then I think I remember my last conversation with him was, what do you know about what's going on with her right now? And he told me what he thought, but he never thought or even considered that she was actively dying. And she did die that morning, but he was so attentive and so concerned and heartbroken because, again, in his mind, she's always come back home after having been sick. So it wasn't so much as a shock to me as it was somewhat disappointing and sad that along the way, obviously, no one had told him the truth. And so his last night with his loved one was not just grieving, but even just trying to understand what was going on.
Yeah, I think sometimes we're just afraid to have those conversations. We don't want to be seen to be crossing a line or saying something inappropriate. But what I've learned along the way is nobody can prepare you for losing a loved one, whether it's someone in your family or whether it's a patient. Be honest with the family and be as transparent as you can and give answers, even if they might not be perfect textbook answers, to at least know that you empathize with them and that you are trying to make that connection with them to help them through this very difficult time.
Your question, Evie, was perfect. Tell me what you know. Doing a knowledge assessment, telling me what you know about what's going on so that I can help clarify any misconceptions or lead you down the path where we can complete your knowledge. That's so important. And that's such a gentle approach instead of, wow, you must be in denial. So I think the way that you handled that loved one was really ideal, figuring out where the level of understanding was, and then what do you need to do to fill in the gaps and get them on the right page.
I agree with Alyssa. And I definitely think that probably caring for end-of-life patients is probably one of the biggest opportunities for interdisciplinary collaboration, because it takes the medical team, the nurse, everyone coming in, making sure everyone is on the same page, making sure that when there aren't any family members who are like, oh no, like we need to reverse their code status, stuff like that. Also want to make sure that the family oftentimes is at the bedside all the time with our actively dying patients saying, hey, if you notice that they're uncomfortable, here's what you can do. You can call me and I can come give their medicine. Or oftentimes if listening to the family member says, hey, I don't think my patient is very comfortable, okay, then I can then report back to the doctor, hey, I think we need to get like a PCA pump to get some continuous basal dosing in there somewhere.
Wow. So this is a tough subject, but I guess it's one that we don't often have. And when we have these patients that we regularly care for in our time, again, each patient may be actively dying, but there are so many differences among their family members and even the patient's needs or experiences at that time when they're actively dying. I remember another situation where our patient was actively dying and the family were more in denial. And there was a lot of anxiety there, and they wanted to continue feeding the patient or giving the patient something to drink. And so I spent some time trying to be compassionate and gentle and explaining that those sustenance items were not necessary now. And we were doing our best to make the patient as comfortable as possible. And I think it's okay sometimes to just give the patient's family, just be silent and let them vent, if you will, give them that moment, give them that time. I know it's very difficult. I've been there. I've lost loved ones. And from a personal experience, I know it's difficult. And sometimes the silence and just them knowing that you as the nurse, you're there, you're listening. even though it's nothing that none of us can do at this moment, except make the patient comfortable.
I think that's a really good point, Evie, is just that presence, right? Of I'm here with you. I may not be able to fix this for you, but I will stand with you while you experience this. I think that can be really powerful for families that are grieving. And it's interesting because we have our own feelings and our own emotions as we're watching our patients go through this. When I talked earlier about, I've got 4 patients that are doing great and they're going to go home tomorrow. And then I have to calm my own energy and enter this room with this very somber family. You have your own feelings, your own thoughts and feelings, your own opinions about what led you here, taking care of a very wide variety of patients who were dying for a variety of reasons, right? So sometimes it's something that you're like, wow, this was totally preventable. You could have not lit a cigarette with an oxygen tube on your face, and then maybe you wouldn't have burned your airway and led to this. That's an example.
Yeah, I think there's a couple of things to add there. I always do much better with patients than I do my own family and friends. I've been fortunate that I haven't lost many family members, but I've lost several friends along the way to cancer, and I've not wanted to go see them, to go visit them, because I'm thinking, what will I say? What will I do? And then when I get to work, I guess you just put your game face on and you're still compassionate and you're still caring, but you have that detachment, even though you become attached to your patients. I think it's also a sobering moment to be there the second someone passes away. To sit and take their last breath is almost as powerful as watching a baby be born. And again, working on Med Surg, it's not the norm. It's not a hospice floor. You don't expect these things to happen. And on more than one occasion, I've had to find myself having to step away, take a moment, because in the busyness of the day and patients wanting pain meds and patients wanting this, that, and the other, someone has just lost a loved one, and you just can't hurry that along, and you have to take your time. Family have to be called, family have to come in. And then I think it's really important to recognize that we'll need a moment as well, just to take stock as to what has happened before. Unfortunately, you have to brush yourself off and then go back to the land of the living. But I think the core of what we do is caring. And that's one of those moments when you think, okay, I can switch these emotions around. I can do this and I can reconcile what's happened. And now I'm going to move forward. But it's not always easy, especially if it's totally unexpected, or if it's someone perhaps that's younger. Death at any age is not something we wish for, but it's going to happen. And it's a little easier to reconcile again if someone's older. And
great point, Caroline. We do need to take that time, and we do need to take that breath, because in the med surg setting, having a patient pass away or be on palliative care is not the norm, at least in the organization that I grew up in, right, with my nursing career. We had a palliative care floor. If the patient was going to be put on palliative care while they were admitted to a med surg floor, we transfer them and send them to the experts. Unfortunately, that didn't always work. They may not have a bed, or the decision to transfer care to palliative was made so late that the death was imminent enough that a transfer of care wasn't really worth it. I guess you could say the family was more comfortable where they were. The patient would be more comfortable where they were. And so ultimately we left the patient on our unit. And so it's not the norm. And while I think it's a very valuable skill that every nurse should have, the ability to work with a patient who is actively dying, it's not a skill set that was really focused and nurtured in my area. So one of the things I'm really proud about is that when I got into education, that was something that we worked on fixing. We worked really hard with our palliative care team to create care of the dying patient education for all acute care nursing. And then there's a more advanced level for our ICUs and all of that kind of stuff, because we just don't want to leave our nurses with no guidance on how to tell when a patient is actively dying, or they are now suddenly on a morphine trip. And yesterday, I only did morphine every 4 hours, and the patient had to be requesting it and X, Y, and Z of how we do pain meds and med surg. And now suddenly they're on a drip, and the palliative care team is telling me to turn it up, even though the patient isn't saying anything. And all of these changes in thought process on how to manage a patient who's actively dying. We needed to let those med surg nurses know what they were, what the rationales were, and how to recognize that patient as they are transitioning through the phases of death.
I agree with Alyssa. I definitely think more rigorous education needs to occur. Before we were primarily a med surg unit, we were geared towards palliative care. So we have anywhere between 5 to 7 palliative care patients. So these days we're more med surg focused, but we still get those palliative care patients. Talk about the fear of giving the last dose. I think that a lot of people who don't take care of palliative care patients are always fearful that the dose they give will be the last dose. But to our listeners, you have got to manage those signs and symptoms of death, because when you are dying, you are having end organ failure. All sorts of systemic things are going on in your body. Your lungs are fluid filled. Actively dying patients can't manage their secretions. So it can literally sound like and feel like that you're drowning. If you have any questions about caring for an actively dying patient, don't be afraid to reach out to your management to get those education tools that you need. And just remember to always collaborate with whatever primary team. Something that I've seen across hospitals is that they're starting to get palliative care teams that can come on and consult patients who happen to be actively dying or choose to go hospice. They will consult them before they leave the hospital. But palliative care teams also work with chronic pain management patients, so they can also be used for that. So just tap into your resources.
Chelsea, you mentioned some good points, because on the unit where I work, we do have a palliative team as well as hospice nurses that we coordinate with, and they will come there, particularly if the patient is comfortable and that's where the family wants, like Alyssa was talking about. So it makes a big difference to not have the patients transferred so much. And if the treatment can be given and the care can be given where they are, then why not do that? It makes the best sense for the family and for the patient. And even I would suggest it makes the best sense for the staff, because oftentimes once a patient leaves to go to palliative or hospice care, the primary unit that or nurses that were caring, we don't have the closure. We don't know what happened. So I think that's a benefit, if you will, that we can have closure and even talk about our grief and our loss as well for our patients at that time.
Yeah, I couldn't agree more. I think that's really important. And oftentimes being in acute care, we transfer our patients either to hospice or to palliative care. We never know what happens unless a family member comes back. And of course, because of their grief and their grieving, it could be weeks or months even when they come back. But I think closure is very important for the healthcare professional as well, because we need to know what happened in the end and if everything met the needs of the family, for sure. It's interesting because talking about palliative care, it's probably good for our listeners to understand the difference between hospice and palliative care. I've just did a little bit of definition here. And of course, palliative care is not necessarily meaning the end. We can look at any chronic illness, and typically palliative care is started in hospital. Hospice, of course, when all measures or all treatment options have been exhausted, the physician has that difficult conversation with the patient and the family and puts a time frame on life. And that's always hard for me to understand. It's like, how do you know this patient has less than 6 months to live? And that's the number that we use for hospice care. Collectively, though, both of these wonderful support systems will reduce stress on the family, stress on the patient even, and offer symptom relief, pain management that's related with the illness, and also that physical and psychosocial relief of the family, because it's mentally exhausting. Physically, it can be exhausting. So the two obviously connected, but it is important to understand that there is a difference for sure.
I think that's great that you bring that up, Caroline. The educator in me was going to do that too. So you can tell that you and I are along the same thought process. I'm like, yes, let's give some definitions. But really,
always the educator.
I know, we can't help it. But really what I wanted to ask is if anyone has a patient death you'll never forget, because really those are the things that kind of stick with us throughout our careers.
I will never forget the first patient that passed away. And it was an elderly patient, and I was working in a rehab facility. I hadn't even started my nurse training, and she was on her own. And that to me was the saddest thing right from the get-go. This little lady was there on her own, and I don't remember if it was expected at all, but it was just very emotional. very upsetting, but also very reassuring to see the way that everybody respected this patient and how they cared for the body before the family came in to say their goodbyes and the patient went off to the funeral home. I also remember my youngest patient that passed away, and it was when I was working on a kidney transplant unit. There is an area of optimism, if ever there was one. And this patient, unfortunately, threw a clot, we think, and just literally dropped dead. It was sudden, it was unexpected. No one had any idea. And I will never, ever forget how heartbreaking it was to see this young patient's wife, newly married, the rest of their life ahead of them, and have to tell them that her husband had passed away. That was probably one of my most shocking incidents and stayed with me ever since.
I have a memory, and I think I was a relatively new nurse, and I think this was probably my first time having a patient, that was actively dying. And I remember going into the room to check on the patient, and I heard this sort of deep breath, or this letting out a lot of air. And at that time, I did not realize that was the last breath of that patient, because I left out of the room. And then maybe 15 minutes later, I went back and the patient was deceased. And it dawned on me, and I thought to myself, wow, that was the last breath. And I just didn't realize it at that time that that's what it was. That one will stick with me because I don't think I've ever forgotten that. But then I thought later that how many maybe new nurses didn't know that or wouldn't know that either.
Yeah, I definitely always will remember my first patient as well that passed away. Mine actually was during my nursing internship. I did a 1.5-year-long internship on the unit I was hired onto while I was still in nursing school. And one of the patients we took care of, maybe a year into my internship, they decided, in the middle of our shift, the patient had decided to withdraw care, which was very strange to me. I really didn't understand. I'm like, you're on a Med Surg unit and we're taking care of you. Why would you suddenly withdraw care? And so we transferred the patient into a larger room on the unit. At the time we had shared rooms and we had a couple of larger rooms that were singles. So we moved the patient. And then I was the one giving those initial doses of morphine as we were transitioning the patient, because the patient had a condition with her lungs where basically the lung tissue was becoming so stiff she could no longer breathe. And that's why she decided to withdraw care. And so I was pushing the morphine while we were taking off the oxygen. And it was the scariest thing I had ever done. The patient did pass right at shift change. And I was new and I was an intern, and I was curious about what was coming next and what the next steps were for preparing the patient and working with the family. But at the same time, I was horrified and traumatized a little bit about my day. And so when my nurse was like, you can go, you don't have to stay for this, I did. I left. I was like, okay, great. Because I did need to go deal with my own emotions and my own feelings. That patient will stay with me forever.
So we had an older lady that was dying from ovarian cancer. It was just at the end of the road there. And it was my first time taking care of someone who was end of life. And so her husband came out and was talking to us, and she had lasted a little longer, actively dying for 2 weeks at that point. And he and his son he was just relaying to us how he and his son were emotionally spent, because it was this 2-week process of waiting and waiting. And I just teared up. Just the way that he was talking and how emotionally burned out he was. It was just so sad. I had to excuse myself.
And I don't think there's anything wrong in showing your emotions. It makes even more of a connection with the family who realize you're not just going through the motions and this is truly not a job. Life is part of death. And I think that as long as we keep an open mind and are willing to support and empathize in whatever situation we're faced with, that just makes us more human and makes more of a connection between the patient, the family, and the caregiver.
Absolutely.
We look forward to connecting with you on the next episode of Med Surg Moments, the AMSN podcast. In the meantime, we want to hear from you. Send us your questions, topic ideas, and feedback to amsnpod@amsn.org. That's amsnpod@amsn.org.
We'd also like to remind you to become a member of AMSN or renew your membership at www.amsn.org. You receive lots of cool benefits and perks, such as discounted pricing on the annual convention and continuing education.
We encourage you to help us spread the word and subscribe to the Med Surg Moments podcast via your smartphone podcast app to receive notifications of future episodes. Please be sure to leave us a review and recommend Med Surg Moments wherever you get your podcasts to help us reach even more listeners.
We invite you to join the conversation by sharing your ideas and questions on AMSN's Facebook, Instagram, LinkedIn, or Twitter pages. And don't forget to add #MedSurgMoments to your posts. Simply enter AMSN in the search field on any of these social media platforms to connect with us.
The content within the Med Surg Moments podcast represents the views, thoughts, and opinions of the co-hosts and may not necessarily reflect the views, thoughts, and opinions of the Academy of Medical Surgical Nurses.
Until next time, I'm Evie.
I'm Chelsea.
And Alyssa. And always remember, Med Surg Moments is a moment in our lives, a moment in our med surg careers that makes a huge difference.